Hi everyone, welcome to our multi-heart lecture series. Today we'll have Dr. Michael Liu from MGH, who will be speaking about primary cardiovascular prevention in HIV, impact on coronary artery plaque, inflammation, and cardiovascular events in the REPRIEVE trial. Dr. Liu is a director of AI and co-director of MGH Imaging Research Center, director of the MGH Imaging Training Trial Center, and Associate Chair of Imaging Science for the MGH Department of Radiology. He's also an Associate Professor of Radiology at Harvard Medical School. He's the co-PI of the Data Coordinated Center for REPRIEVE. This is the randomized trial to prevent vascular events in HIV that he will be talking about today. And he's very well published. Dr. Liu has over 150 publications, including important journals like New England Journal of Medicine, Circulation, JACC Imaging, Nature Communications, JAMA Cardiology, JCCT, and many more. So it's a great honor to have you here today with us in this very important topic, and congratulations again on all the amazing publications and work you've done.
Thank you, Leandro. As I mentioned before, it's great to talk here at Montefiore. Some of our recent fellows are, I believe, faculty with you now. So again, great to have this opportunity to talk about REPRIEVE. Before I get into this, I want to mention some important disclosures. The REPRIEVE trial was funded by the NIH via the NHLBI and the NIAID, but also via several industry partners. We also had supports from the AIDS critical support from the AIDS Clinical Trials Group. I have several unrelated disclosures. My institution receives research funding from a variety of other groups that are unrelated. So the background of this, and I think if you're tuning into this, you probably are interested in this. We know as antiretroviral therapy has improved, people with HIV are living longer and are actually, at least in the high income world, meaning including the United States, are more likely now to die of non-HIV related disease, such as cardiovascular disease and cancer, than HIV infection itself. So with that, there has been a lot of focus at looking at those other causes of death, which we know can be accelerated by HIV, and ways to prevent those diseases and improve quality and quantity of life for these folks. Past research has shown that people with HIV have about 1.5 to 2 times the risk of cardiovascular disease relative to the general population. And often this is characterized by a higher level of inflammation caused by the HIV infection and a higher burden of non-calcified coronary plaque. Often you'll see younger people developing plaque earlier with HIV. Now, we have treatments to prevent cardiovascular events, statins being the most established one. Statins have pleiotropic effects both on cholesterol, but also on inflammation and immune activation, and as we've demonstrated previously, looking at coronary plaque. Pitavastatin is a moderate intensity statin, which has minimal interaction with antiretroviral therapies in HIV, specifically because it's metabolized via a different pathway. So it's a potential drug that could be used in this population. Looking at the general 2019 ACC/AHA primary prevention guidelines, I wanted to point out 2 things here. One, there's this low to intermediate risk category, 10-year ASCVD risk, less than 5 to less than 20%, where there's a discussion about whether a statin is right for a patient. And specifically, this discussion can include so-called risk enhancers, and there's a long list of risk enhancers the guidelines set forth: family history, cholesterol, metabolic syndrome, but also importantly, inflammatory diseases, including HIV. However, at the time that these guidelines were made, there was not sufficient evidence to really, come down hard on whether people with HIV, say with a borderline risk, ASCVD risk of 5%, whether those people should be on a statin. And that's really what we tried to, again, the trial was started actually in 2014 and 2015 before these guidelines, but that's what we wanted to look at in REPRIEVE. So I'll present slides today that are based off this publication in the New England Journal last August, and also some slides from Steve Grinspoon, who presented this at IAS in 2023. This is the randomized trial to prevent vascular events in HIV, a phase 3 randomized controlled trial of pitavastatin calcium 4 mg per mouth every day versus placebo to prevent major adverse cardiovascular events in asymptomatic people with HIV on stable antiretroviral therapy at low to moderate ASCVD risk. So here's the general schema of the trial. We enrolled asymptomatic people with HIV on ART at low to moderate risk, as I mentioned. There were 7,769 people overall, excuse me. They were randomized to placebo or pitavastatin. And then in the main study, we followed them for the primary clinical endpoint, CVD death, MI, UA, TIA, and stroke, peripheral arterial disease. Then in a sub-study, which I'll talk about in the second half of the talk, 804 of those participants, excuse me, had coronary CT and extensive blood biomarker testing when they started in the trial and then after 2 years to look at changes, how pitavastatin affects changes in coronary plaque, inflammation, and immune activation. For the first half of this talk, I'm going to talk about the main study where we're looking at cardiovascular events as the primary endpoint. Major inclusion-exclusion criteria, age between 40 and 75 years, HIV on stable ART, as I mentioned, no known ASCVD, and then there were changes to the entry criterion around the time of these new guidelines, but the overall entry criteria were based on ASCVD risk score and LDL. So an ASCVD risk score up to 15%, so long as your LDL was less than 130 mg per deciliter. Exclusion criteria were concurrent use of statins, gemfibrozil, or PCSK9 inhibitors, and known cirrhosis. This was a global trial enrolling 145 sites from 12 countries. So there was, the trial actually started out as North America only, but we were able to get additional approval to get additional sites from South America, Africa, Asia, and it's not on this particular figure, but also from Europe as well, overall 12 countries. Now let's get into the results. These are the baseline characteristics of the study. The median age was 50, and most people were between 45 and 55 years of age. 31% of the participants were women, and that's lower than we'd like, but not dissimilar from other HIV-related trials in the literature. Race, 35% white, 41% Black or African ancestry, and 15% Asian. And the median ASCVD risk score was quite low at 4.5. Median LDL was 108. And if you look between the pitavastatin and the placebo arms, again, participants were randomized to these two arms. There were no significant differences. Baseline ART regimen is on this slide. The one thing I want to point out here is that these are people who have been on ART for a long time, most of them more than 10 years. So, it's interesting in this trial, those of you familiar with clinical trials will know that every 6 months or every year, there will be a data safety monitoring board that is charged with looking at the, assessing the safety and progress in a trial. One thing about trials like this are that the investigators are blinded to the results of the trial. So, over the 10 years that we ran this trial, almost all of that time, we did not know who got pitavastatin or placebo. We did not know the overall result. But the DSMB is charged to actually look at those unblinded results to assess whether the trial should continue because there's a potential for efficacy or whether it should be stopped early due to futility. So what happened in this trial, we were powered to have 85% power to detect a hazard ratio of 0.7, so meaning a 30% reduction in MACE with pitavastatin, with an overall 288 anticipated events. The DSMB, again, convened every 6 months, and also when we had 75% of the anticipated number of events, and that was at the end of 2023, they reviewed the data and decided to close the trial early for efficacy because at that time it was clear that pitavastatin was preventing major adverse cardiovascular events, uh, and that there were no safety concerns from the therapy, and that the benefits outweigh the risks of the statin therapy. So at that time, the ethical and practical thing to do was to stop the trial early so that these results could be disseminated. So all of the data I'm presenting today are based on this DSMB look at the data, which is basically the data through the end of 2023, with the DSMB stopping the trial around April of that year uh, I'm sorry, yes, the April. But actually, we have additional. I'm sorry. Let me take a step back. It was 2022, so through the end of 2022, and the trial was stopped around April 2023, and then we had our last visit in August of 2023. So with that, there's actually about 6 or 7 months of additional data and events that were collected after this DSMB look. Those will be published soon. I can tell you there were not, that it's under embargo, will be out very soon. There are really no major changes though in the overall message. So again, looking at the data that was in the New England Journal, we had a median of 5-year follow-up, a 35% reduction in the primary outcome MACE, and a 21% reduction in secondary outcome of MACE or all-cause mortality. You can see the placebo group here in blue, pitavastatin arm here in orange, and that then out over 5 to 6 years. So this is the primary outcome of the main trial. Uh, More than 80% of participants in both groups remained in follow-up, which is good adherence. Again, some of these patients, we started the trial in 2015, so some of them had been in the trial for quite a long time, 8, 9 years. Adherence is very good to excellent in terms of taking the study drug. Adverse event-related discontinuation was very low. Initiation of non-study statin occurred in 6% of the pitavastatin arm and 10% of the placebo-treated participants, which is below the predetermined threshold of concern. Why did that happen? Certainly patients who are having events or patients who are having very high cholesterol or aging into a higher ASCVD risk category may be here, whereas patients on pitavastatin we know had fewer events, had probably had lower cholesterol too, so that may explain this discrepancy. All events were adjudicated, by an independent, blinded events adjudication group at TIMI at the Brigham Women's Hospital, excuse me. And this trial also happened during COVID, so that was a major achievement and effort to continue this trial throughout the COVID pandemic. Though in this case, very few of the events were thought to be related to COVID. Looking at the effects on LDL cholesterol, as you would expect, pitavastatin reduced LDL compared to placebo. It's interesting, you see a slight drift back together here, and this, you could talk about why this happened. It could be due to discontinuation of study drug or starting on a statin in the placebo group. But you see, I don't think this is really a big change, but overall there was a lower LDL in the pitavastatin arm. Now we saw a 35% reduction in events, and the people have published that the rate of reduction of events is linearly related to the reduction in LDL. So if we look at past cholesterol lowering trials, we would predict a 17% lowering in events for reprieve based on the decrease in LDL. In fact, the effect was higher, as 35% in this population. And why is that? Some of that we think may be related to the non-cholesterol lowering effects of statins, particularly on inflammation that we know is increased in people with HIV. Now, those were good results. So we saw a 35% reduction in MACE with pitavastatin compared to placebo over a median of 5 years of follow-up in this low-risk group. What does that mean in terms of how you should treat patients? So I want to look here at the projected number needed to treat. So overall in the REPRIEVE trial, you need to treat 106 people to prevent one MACE over 5 years. However, when you stratify that by ASCVD risk score, there's a larger picture here. So, of course, the people who are at higher risk, you're going to need a lower number needed to treat. So 2.5 to 5% ASCVD risk, 150 people. 5 to 10% ASCVD risk, 50 people. And then over 10% ASCVD risk, that's really 10 to 20%. You have 35 people you need to treat. So as you would expect, as the ASCVD risk goes up, you need to treat fewer people to prevent one MACE over 5 years. So in summary, Reprieve enrolled 77,769 people on ART with low to moderate 10-year ASCVD risk. And this is a international study from a number of sites. Participants were randomized to pitavastatin or placebo. And what we found was that over median 5.1 years of follow-up, pitavastatin reduced incident MACE by 35% compared to placebo. And this MACE decrease of 35% was above what you would expect based on LDL lowering alone. These results were from August of last year. And since then, we've actually seen the first changes in guidelines based on this, so a relatively rapid uptake. These are guidelines from the US Department of Health and Human Services, the ACC, the AHA, which they released, I believe I think it was last month. And it really focuses again on this category here and firms up, this from a risk enhancer to a more concrete recommendation on how to treat these patients. So the guidelines in people who are at less than 20% ASCVD risk, so again, in this red box here, people 40 to 75%, the recommendation, A1 recommendation is for pitavastatin, a moderate intensity statin in those persons. And alternatively, there are A2 recommendations for either atorvastatin or rosuvastatin as alternatives. So this is for people with that ASCVD risk score 5 to 20%. And I think that's based off the number needed to treat of less than 50 when you go to 5 to 20% ASCVD risk. So that's an A1 or A2 recommendation. So when you go to an ASCVD risk less than 5%, now you're talking at around 100 to 150 people needed to treat. Sorry, 150 or more people needed to treat in order to prevent one MACE. And here there's a level C1 recommendation to initiate a moderate intensity statin for these lower risk people. They also issued a guideline for people less than 40 years where there's insufficient data to really provide a recommendation. Many of these people will age into being over 40 and age into being a higher risk, higher ASCVD risk. So they will probably end up being on statins eventually. So so I mean, I think it was really great to be a part of this trial. Again, I started working on this as a fellow and junior faculty person, and it's worked on this trial now my entire career as a faculty person. And we publish a lot of work, but overall, most of that work probably doesn't end up directly affecting how people are treated. So it's really really an honor to be involved in this trial, which actually is now really directly affecting how a lot of people will be treated. And very quickly after the publication was made, is now in the guidelines in the US and is actually in the guidelines in the UK, and we hope will be in multiple additional guidelines in the near future. So that's the main trial, Reprieve. I'm going to spend the rest of this talk talking about a sub-study in Reprieve. This is very close to my heart as a cardiac radiologist, looking at how we can use coronary CT or serial coronary CT to look at how plaques are changing in response to this treatment. So this is a study I did, with my DCC co-PI Heather Roboto, CCC co-PIs Pam Douglas, Steve Grinspoon, former PI and my mentor Udo Hoffman, and a number of the CT readers at our group, including Boric, Julia, Yana, and statistician Thomas, over a number of years. So what was this? Within the main Reprieve trial, we had 800 participants, all from the US, who participated in this mechanistic sub-study. And in the sub-study, they had coronary CT at baseline and 2 years on study drug. And they also had blood testing, additional blood testing. The primary hypothesis was that pitavastatin would decrease non-calcified plaque volume and reduce non-calcified plaque progression over 24 months. And we had secondary and exploratory outcomes, including changes in inflammatory biomarkers and low attenuation plaque volume. So the lower attenuation plaque volume we think is more biologically active component of plaque. All right. So coronary CT, I'm a coronary CT person, I would say. So, and the reason we're excited about this is because it allows for non-invasive assessment of changes in coronary plaque. And of course, coronary CT, the strengths of coronary CT are that it's non-invasive, that you can see the entire coronary tree rather than just like one vessel or one segment. But importantly, because of that, you can really do studies in lower risk populations that aren't going to get coronary catheterization, that aren't going to get, who won't be getting IVUS or OCT. It also really helps for retention because it's very easy for a person to, agree to get a coronary CT and another one 2 years later. It's very hard to do that if you're trying to do this with invasive testing, especially in low risk populations like this without known ASCVD, who really wouldn't get any testing at all normally. So that's why we're so interested in coronary CT to look at changes in plaque. Coronary CT also lets you characterize plaque, so you can look at whether plaque is calcified or non-calcified, or whether it's lipid rich, meaning low in attenuation or density, and look for high-risk plaque features. So getting back to the study, the primary outcome in the study was the change in non-calcified coronary plaque volume, which we defined as a attenuation or density less than 350 Hounsfield units, and plaque progression, which we defined as any increase in plaque volume or new non-calcified plaque. We had that low attenuation plaque, less than 30 Hounsfield units. That's the lipid-rich plaque we talked about earlier. And it was powered with a 90% power to detect a 6% difference in change in plaque volume. The data I'll show today is the intention to treat analysis in participants who completed the coronary CTs. So we previously reported the baseline characteristics. We had 804 people overall. Overall, the population was similar to the overall REPRIEVE population, with the exception is that we had fewer women. So we had overall was 31% women. Our study was 17% women. We had similar age, similar racial and ethnic makeup. Time since HIV diagnosis, I mentioned earlier, most of these participants had been diagnosed with HIV and had been on ART for many years. ASCVD risk score was the same as in the main study, median of 4.5. LDL cholesterol also very similar to the main study, around 105, 108. And the baseline non-calcified plaque volume was relatively low, around 50 cubic millimeters. So here's the result. In the pitavastatin arm, we saw a decrease in non-calcified plaque volume versus placebo was a 7% decrease. And again, we powered the study for a 6% decrease. And this 7% decrease is in the overall population. So that includes about half the people who didn't have any plaque. So the thing is, most people without plaque, they're highly unlikely to develop new plaque. So when we look at the subgroup who had plaque at baseline, which is about half the people again, we saw a larger effect size with a 12% decrease in non-calcified plaque volume with pitavastatin versus placebo. And overall, the pitavastatin arm had a 33% lower risk of non-calcified plaque progression compared to placebo. And we did additional per protocol and multiple imputation analyses for missing data, and we basically got very similar results. So this table essentially recapitulates that negative 4.3 cubic millimeter decrease, a 7% full decrease in percentage, and a 33% lower risk of plaque progression. For the low attenuation plaque, we also saw a decrease. The thing with low attenuation plaque, it's a much smaller component of non-calcified plaque, so the change was smaller. Another thing I'd like to point out here too, when looking at these changes, this change again it's a combination of a decrease with statins, but also an increase in placebo. So the natural history with coronary disease, of course, as you age, is to get worse. So that's what was happening here with placebo, and we did see a slight reduction with pitavastatin. Here are two examples of this. This is a participant on placebo. This is a coronary CT of the proximal right coronary artery at entry in year 2. And you see there are two plaques in this patient that are relatively small. They're non-calcified. And then at year 2, these plaques, which are outlined here in blue, have gotten larger. And then here's another patient with a plaque on pitavastatin, and I believe this was in the proximal AD. There's this larger plaque here that actually decreased in size after 2 years on pitavastatin. So these are the kinds of changes we're hoping to see with the statin drugs. Let's talk about blood biomarkers now. So LDL, as I mentioned in the main study, LDL decreased with pitavastatin, and we saw the same thing in the sub-study, a mean decrease of 29 mg per deciliter compared to placebo. Inflammatory biomarkers. So we ran a number of inflammatory biomarkers. LPPLA2 and oxidized LDL were significantly associated. I'm sorry, pitavastatin led to a significant reduction in inflammatory biomarkers, LPPLA2 and oxidized LDL. There was also a trend towards a decrease in high-sensitivity CRP. Interestingly, we saw a bigger decrease at 6 months than at 2 years, though the change from baseline did not meet the threshold for statistical significance. Of interest, we did not see a significant decrease. So pitavastatin did not significantly decrease other biomarkers of inflammation and immune activation we tested, including the ones listed here. So how did the change in biomarkers relate to change in non-calcified plaque progression? What we saw, there were not clear relationships between CRP, LPPLA2, and oxidized LDL with progression in non-calcified plaque. However, we did see that the change in LDL cholesterol at month 24 and achieving an LDL cholesterol less than 70 mg per deciliter, those were both associated with a lower risk of plaque progression. All right, so how did our results compare to other studies out there? We'll have another thing coming out later for CT, but here I'm just comparing it to IVUS and OCT studies that are out there, and this is modified by a figure by Dawson et al. In JACC 2 years ago. Here we're looking at the percent change in plaque, and on the x-axis you're looking at the achieved LDL-C, and we achieved an LDL-C of a median LDL-C of 1.9 millimoles per liter, so that's around here. And if you look at that, we essentially saw a 7% decrease in plaque volume. So this is essentially, within the range of expected, according to these other IVUS and OCT trials. It's a little different because our trial was in a much lower risk population and we're using coronary CT instead of IVUS. But even allowing for that, the reduction in plaque volume was similar to what you would expect given the change in LDL. I mentioned earlier how the 7% is in everyone, including the half of people who didn't have any plaque, when in fact we looked at people with plaque at baseline. This is lower, it's more down here, and so a higher effect if you were to only consider people with plaque at baseline. So in conclusion, in this primary prevention cohort of people with HIV, a low to moderate CVD risk, 24 months of pitavastatin led to a decrease in non-calcified plaque volume by 7% and a decreased risk of plaque progression by 33%. There was also decreases in oxidized LDL and LPPLA2. These changes in non-calcified plaque may contribute to the 35% reduction in MACE that was observed in the parent reprieve trial. And it's thought that In other studies, IVUS studies, it's thought that as small as a 1% decrease in plaque can have a major reduction in the odds of MACE. So those are the slides I had to present today. I want to take a moment to thank the many, many people who have been involved in Reprieve over the last decade. First of all, of course, the many participants who donated their time and effort and took a study drug, which they didn't know whether it was placebo or pitavastatin, sometimes for up to 9 or 10 years. The many, many people at the main study sites and the sub-study sites who collected all this data over years. Our colleagues at the Data Coordinating Center, including the Harvard School of Public Health, Frontier Science, the TIMI group who did event education, and then our group who did a lot of the event collection and also ran the CT Core Lab, as well as the Reprieve Clinical Coordinating Center and our sponsors, NHLBI, ACTG, and DAIDS. All right, so that's what I had to talk about Reprieve. I'd be happy to address any questions you'll have.
Thank you very much. What an important work you've done, and it's really well presented as well. So thank you again for this. So if anyone has any questions, please put them in the Q&A and we'll go through them. I'll start with two questions. One is obviously we're showing that this group of people have more aggressive disease, or the ASCVD risk is underestimating the risk. The first question is, should we wait until they're 40 to start considering this and treated them? And the second question is, we showed that the lower the LDL, the more changes in plaque, and any idea of further trials coming with more aggressively lowering therapies?
Yeah, so I'll address the first question first, and I think it was about, does the ASCVD risk score accurately assess? Does it accurately predict events in HIV? And then what do you do when someone's under 40? So for the first part of it, there will be that's something we're looking at. How well the ASCVD risk score works in HIV, in Reprieve, excuse me, and are there subgroups where it may work better or not? So that's still being worked on. I think there are certainly a lot of scores that are out there and may work better than the ASCVD risk score. I think the thing is right now we're kind of, the guidelines are really based on the ASCVD risk score for better or worse, and that's sort of what we have to work with. And I mentioned the guidelines, briefly in passing here, but I know an enormous amount of effort went into putting this in, and I know these discussions are always difficult because, of course, is the ASCVD risk the right thing to use in HIV? That's debatable, but it is what the guidelines are and what the community has coalesced around. The second question, so people under 40, should they start going on a statin or not? And I think, Reprieve was 40 to 75, so we don't have any information on people under 40. I can tell you as a person who does coronary CT, you don't see a lot of plaque in people under 40. I mean, certainly there are people under 40 with a lot of plaque, but it's rarer. So, I'm not really sure and also as a radiologist, I don't actually give statins to people every day, so you all may be in a better situation for that. But I think from talking with people, I mean, I think it's really an individual decision. Certainly a lot of these people in their 30s will age into this 40 plus category, so they will go on a statin later. As the timing of that, I think that's a discussion with the person, with the patient. It may also hinge a bit on, of course, preference is probably a big thing, but also these other risk enhancers that we know are related to ASCVD, even if we don't have a good quantification of that yet. So I don't know if that addresses that first question.
Yeah, for sure. Thank you very much.
Now, the second question, help me if I didn't remember this correctly.
Yeah, so I mean, how aggressive we should be, because you're showing that the more aggressive we are, the ones that have, LDL below 70 had even some benefit and more regression. And
Whoops. Yes, so that's a good question. I think from the IVUS literature, we know, it's well known that basically the lower the LDL you get, usually the more plaque regression you get, and 70 is one of those thresholds that people have used. There are trials that are currently underway with PCSK9 inhibitors. We're actually the core lab for another trial of PCSK9 in HIV, and I think there are others out there. So those results will, don't know the answer yet, but those results will come out. And it's unclear because, of course, statins effects, I think, are beyond just the LDL lowering. There's also the anti-inflammatory effect, and whether we'll see that with these other drugs is not clear. So I guess I would say I don't know, but hopefully there'll be more data coming out soon.
That's great. Thank you very much. We have one question from Daniel Lorenzati. Thanks for sharing your interesting work. Do you think that there is a role for calcium scoring in this specific population, or would you prefer or recommend CCTA instead, even in asymptomatic maybe, due to the
Yes,
chance of finding non-calcified plaque?
Yes, that's a terrific question. So, in the 2019 ACC/AHI guidelines, coronary calcium score is suggested as a decision maker in people who are not sure or reluctant to take a statin. And it's a relatively cheap test. I mean, it is very low radiation dose, depending on where you are, anywhere from $100 to $300 usually, even though it's not covered by many insurance carriers. So that's sort of what's been established by the community as the imaging test to assess for coronary disease. However, in HIV, you make a good point. We and others have shown that people with HIV tend to have plaque earlier. They tend to have non-calcified plaque. And in fact, we will have an abstract coming out this summer, which looks at, people with a calcium score of 0. Does that really exclude you having plaque? And it doesn't. It doesn't really. So I think be a little careful here. I mean, I think calcium scoring is probably what the guidelines recommend. Coronary CT could be helpful in people where there's a question, I think. Though certainly none of the guidelines or most insurance companies, I think, maybe not support that at this time.
Yeah, that's great. Yeah, I agree. I mean, usually we know about 10 to 16%, right, have non-calcified plaque, but in this case, it could impact your therapies, right, more aggressively below it, maybe.
Yeah, it could. I mean, I think the other thing too is, we have patients we scanned and we saw the plaque. But if you take a step back and just look at Reprieve, the 7,769 people, excuse me, most of them did not have any scans, and they were given pitavastatin, and it reduced events. So I think another argument for that is if you do meet these guidelines, should you just give pitavastatin anyway without having any imaging evidence of plaque? Of course, the imaging, of course, can be very convincing, I think, to help patients understand that this is perhaps a good idea to do it. But looking at the overall results of Reprieve, in this 40 to 75, greater than 5% ASCVD risk category, there's an argument that they should just all be on statin anyway.
Yeah, I guess that's what I was going with my point, and probably just putting everyone on statins. They're very well tolerated, but your median LDL still comes to around 70, right? So if you have plaque, probably with the new data on PCSK9 inhibitors, you may want to push it even lower.
Yeah.
I guess so. We have from Dr. Shooter, our specialist in HIV. He says findings of this sort are of great value and influence in changing practice in a positive way. However, research tends to promote tunnel vision restricted to a particular focus of a given trial. What do you think of integrated approaches that target smoking, tobacco use, lipid statin use, hypertension management, etc.? So as a comprehensive preventive approach versus
Yeah,
just
that's absolutely important. In Reprieve, there was a lifestyle intervention that was applied to all the participants, though that wasn't the focus of the study. So, yeah, no, certainly, I think that's important. We didn't directly address. There wasn't a randomization to that lifestyle intervention or not. So I think that, of course, is very important. Uh, I'm not sure if I'm necessarily the best person to speak to this, again, being a radiologist. Perhaps you all could have some other thoughts.
I
Yeah,
think it's important. I mean, I think you can go both ways, right? It's important to individualize one effect, but also it's important for a patient care decision that you can do all these things together, and we expect an even larger impact. And there's trials, from Clearly and some by Dr. James Min that are kind of taking this more aggressive preventive, throwing all, to the prevention to the patients with plaque. But to individualize each treatment, we need trials like the one you did. That is, I think, extremely important with the markers to know which intervention leads to each change, right?
Yep.
Great, very important. I guess we don't have any more questions, but this was, a great pleasure to have you here, and so much more. Again, we know that HIV leads to higher cardiovascular risk, but there's still so much more work to do and to understand how to treat our patients. So thank you for everything you've done.
Thank you very much for the opportunity to speak and talk about Reprieve.